Dr. Sridhar Sivasbbu. He's the Chief Diagnostic and Research Officer and Laboratory Director at Karkinos Healthcare. His primary focus lies in human genome sequencing, its translational impact on healthcare. Sir spearheaded India's first whole human genome sequencing initiative, and this was later expanded to thousands of genomes. His pioneering work in genomics has significantly advanced the diagnosis and management of genetic disorders in India. Today, his talk is on population genomes to precision medicine, impact on public health in India. Stage is yours.
A very good afternoon to all of you, and at the onset I thank the organizers for the invitation, and it has been a very happening morning as we saw, so I hope we continue that to the evening. But what I'm going to do in the next 20 odd minutes, you heard Madam in the morning, just before me you heard Vinod in the morning, how genomics has come to impact medicine and almost creating this genomic medicine as a field itself. I could envisage maybe in the next decade. I hope it comes through. But a cornerstone to all of this is how do we use genomics that we do for population scales into precision medicine practice, and what do we have to learn from it? Most importantly, can we convert that into public health benefits? Because largely it's a high-end test, so there is a cost to it. But if we cannot prove that public health benefit, it remains very exotic. So that was the intention of trying to see if we could derive public health benefits from it. But for all of you pretty much here, you know, the defining time in our lives, if I were to define in terms of academic lives or discovery, something that happened, was largely the sequencing of the human genome, and that credit goes to Frederick Sanger, who really put out the technology for sequencing chemistry, and that led to the first reference human genome. And the two gentlemen, other than the former president of United States on the screen, one is Craig Venter, other is Francis Collins. Both of them led completely different approaches to sequencing the first two reference genomes, but arrived at almost the same answer, that 99.9% of the bases, if I were to sequence anybody here, would be very similar. That means there is a small defined percentage of sequences between us, differences between us, that actually decides why we look different, why we behave different, why do certain pharmacological agents behave differently in certain people, why do we have diseases and others don't. So documenting that small difference is what is called as precision medicine, and how can we use that to tailor medical decisions. And therefore it's all about me, it's all about you, that small difference. Okay, that's what I'm going to focus on. So again, a version of this slide was shown to you. This slide is almost now about, I would say, 18 and a half years old. Okay? The reason why I'm saying it's 18 and a half years, because when we first did the human genome, in a minute I'll show you, that was in 2008, that was India's first genome, everybody asked us a question: what use is a 80 lakh rupee test to a country like India? It was costing us 80 lakh rupees those days. It was the first time somebody was doing it. So we came up with two different things. We said, well, you could use that to answer genetic diseases, and more importantly rare genetic diseases, because India seems to have about 70 million people who go through random about 8 physician visits, 3 misdiagnoses, and wait for 7 years to a proper diagnosis. So that was an interesting question to answer for us. Okay, and that led to a larger question: why would India benefit? One, we are a large population, one of the largest in the world. We have a diverse ancestry, but still stratified into communities. We saw one such stratification that Madam just showed. We still maintain close-knit family structures. So many of us can go back a few generations and recollect who our forefathers were, and poor representation in the global populations. So what would occur in a very rare instance in the world around would occur in a few thousands. Okay, which means genome sequencing can be used as a tool. So this is one of those first times, and you still see Rajesh Gokhale on there. He was 15 days into his directorship when we put him on the stage for the first human genome that Vinod and I sequenced, and that was December 2009. And the two PhD students who did that pictures are out there along with Vinod. So that was sort of the defining moment. But we didn't stop there. We went ahead and sequenced the first Sri Lankan, the first Malaysian, blah, 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 all of that. but also led a number of programs sort of to understand that small difference between people, because that was the fundamental requirement. So I'll show you. The other program that we really came up around 2015 was Genomics for Understanding Rare Disease India Alliance Network. This was a loose, self-volunteered group of clinicians, scientists, about 300 clinicians across 70 centers, where any patient for whom we did not have a good provisional diagnosis or had a diagnosis but didn't know the mutation, okay, the clinicians were asked to volunteer and send the samples. Sequencing was done free of cost those days, and finally, if you found the mutation, you give it back to the clinician to counsel the patient and the family. And if you didn't know anything about it, of course, we had a molecular biology lab which had a lot of model systems. We could take it into the lab and try and find answers for it. So this part was the key there. Apart from the regular sequencing, of course, we know did a fantastic job of setting up the informatics and turnaround times and the compute around it. And all this was funded by CSCR as a demonstrator to sort of encouraging the development of the field. So that led to this large publication which largely documents about. I would really urge people who want to set up large collaborations to at least look at it, because it only doesn't talk about sequencing. It talks about how do you educate people, how do you diagnose, how do you implement and convert it into a policy. And a lot of authors, 280 authors, 70 institutions. But largely we did three things. Okay. We would do either, if you knew the mutation and we have very good idea about it, we would request people to do genotyping or a Sanger sequencing, which we usually did not do. Our partner institutions did it. But we would largely do a whole exome sequencing, which is about 2% of the genome, or do whole genome sequencing. Practically would cover the full genome. And for this audience, again, not something new, that each single gene test versus multi-genes versus exomes and genomes each have their presence and utility in this toolbox of genetics. And you can use them appropriately. And what it does is, it tries to identify a mutation, use a bunch of bioinformatic tools, and find the causal variant in it. Okay, that's all it did. And here's, I'm going to tell stories that are of public health utility from now on. So this is again one of those first cases that was referred by the President's office, the President of India's office to us, saying that there is this unusual family that has written to them asking them euthanization of all their kids that you see who are in vegetative states. Okay, and they had a rare neurological condition. And working along with Dr. Shefali Gulati at AIIMS New Delhi, we documented this family in great detail. In those days, we did whole exome sequencing and identified a mutation in a gene called as MLC1. This is a novel mutation. It has not been seen before in literature, so we didn't know what to do about it. So we quickly said that if so many members are affected, are other family members and community members affected? So we went around about 62 families, I believe, was taken in this case, and all of them, interesting story, history coming from them, that they all belong to a single community called as Nalband, and this community came along with the Mughal army and stayed under the ramparts of the Red Fort in Agra. And the mutation has been there in the community. It's a founder mutation. As you can see, almost 10% of the community members are affected. About 28% are carriers and the rest 62% are normal. Between 2016 and 19, we found the mutation, called it Nalband, did the scientific requirements of publication, also put the diagnostic test out in the market, which is now sold by Lalpath Lab. So you could see now people don't have to do genome sequencing. They can largely do a single gene test because the mutation is a known, and about 50,000 members of the community benefit from it. But to do such kinds of things, we need to understand what is prevalent in our population. So again, Vinod's lab and my lab, a lot of interesting people came together to sequence about 1,000 odd genomes in our country. There are voluntary healthy genomes, apparently healthy genomes, and the program is called as the IndiGene program. And each of these balloons that you see is an individual or a group of individuals from whom samples were collected. And all this is published now. All it says is that there are about 18 million novel single nucleotide variants that we could find in this corpus of 1,000 individuals. Now, you could use this information in multiple ways. They are apparently healthy, but they are also carriers of a lot of mutations, a lot of variants. Could you use that to estimate what is prevalent in our communities? Okay, like I said, in other parts of the world, if it is a rare event, okay, in India it will be 1 in 1,000. If it is 1 in million elsewhere, we will easily find 1 in 1,000 here. So could we find treatable genetic diseases from this approach? Could we look at variants that give adverse drug reaction, or prevalent cancer susceptible genes, or population specific diseases? That's what we did. So boiling the whole thing down, this slide is probably the most important slide of this whole talk, is to what can you do when you have a program where you do large scale genomics. Morning we had a lot of debate of should we do genomics, should we do whole genomes or not do whole genomes. Okay, this probably says that one of the major utilities of doing whole genomes in an unbiased approach is to look for prevalence of what ails our communities. Okay, and for example, sickle cell we discussed, thalassemia we discussed in the morning. 1 in 20 carriers you would find. You could convert that to a national program. Treatable intellectual disability is a very large component, about 1 in 100 carriers you will find. Wilson's 1 in 200. Cardiac channelopathy is one of my favorites, 1 in 100. And so forth, familial hypercholesterolemia, mitochondrial disease, pharmacogenomics, hereditary cancer, and ataxias, okay, in specific communities. And all of these occur at a population scale and size that could be converted into either a state program or a national program, amounting to about 30 million genetic tests that are required every year on year. That's a number that becomes public health important. The genomes is a ways to the means to it. Okay, I'm going to give you 3 examples of how you convert. Okay, in case of primary immunodeficiencies, working along with Dr. Geeta Govindaraj at Calicut Medical College, between 2018 till 2020, we identified a set of patients who had mutations and in genes that cause primary immunodeficiencies. And all of these you could treat with intravenous immunoglobulins. Okay. So if you knew the mutation, you could put them through a treatment. Now what we, along with Kerala government, we ended up doing, and Madam ended up doing, was to convert that into a program where the Kerala government funds patients for hematopoietic stem cell transplantation. Okay. So you could see, you could now not only provide treatment, you could provide remission, you could also use that for the next generation in terms of prenatal screening. So you could almost stop the genetic disease from occurring in this particular community, which is a large community from Kerala. Another example from South Tamil Nadu, along with Dr. Radha Mahadevan. Again, when we started looking at it, Dr. Radha counted about less than 20 internationally known families with this particular condition called as familial adult onset myoclonic epilepsy, FAMI. Okay. A couple of whole genomes in this community, we ended up discovering that there is not few families, there are 434 families spread across 3 districts of South Tamil Nadu, making it the world's largest cohort for this particular disease. And it's a treatable condition. If you knew the mutation and you could document the mutation, you can treat them. Okay, and they don't get the epilepsy after that. So it has a potential impact. The community members, about 8 to 10 million community members spread across Southeast Asia, become the receiving population. So again, 4 or 5 genomes in a few families, converting to a large scale benefit and a simple assay. It's now a Sanger sequencing assay, a repeat expansion. It's a pentanucleotide repeat. Okay, and it is done in a medical college. Doesn't require high-end infrastructure. This is one of my favorites, is cardiac channelopathies, which cause sudden cardiac death. Again, looking at 1,000 genomes, we could predict that about 1.4% of the individuals actually had a pathogenic or a likely pathogenic variant. Okay. But sudden cardiac death is a very unusual thing. Okay. How do you have to wait for the person to die to prove that that's a pathogenic mutation. That's one way. The other way is to go back to clinics with well-documented families. In this case, 53 families were well-documented using treadmill assays, Holter assays and everything, and had other family members who had died. And we asked how many of them mutations you overlap in these families. And we found substantial numbers to overlap there. Okay, so we were able to prove that these mutations are not benign. They are actually mutations waiting for the patient to meet the trigger. If the patient were to meet the trigger, then they would have an episode of sudden cardiac death, and they would have to rush to an emergency room. So clearly it's a treatable, preventable condition, and 1% of Indians is about 1.7 crore individuals, 1.4 crore individuals today. That's a large number, and it's a treatable condition, the 30 rupee treatment. Okay. Again, all of the data is published. So, while we were doing exomes, we realized that we are getting a lot of exome negative cases also, but phenotype positive. So, what Vignesh ended up doing here was take them up into a reanalysis and a whole genome program and added 12 more percentage. Okay, and one more reason why we should do genomes is because the positivity increases, and now at scale genomes almost cost as much as an exome. So why are we not doing when there is a clear benefit in identifying prevalent genetic diseases that otherwise are thought that are not prevalent or are rare, and use them. If they are treatable, put a treatment regime in place and convert it into a public health program. So after 22 years at the Institute of Genomics and Integrative Biology, I decided to make a change in the career. And it was a surprise to many, but clearly to the people who believed in this whole public health program, it made sense that we needed to sort of scale up the program. So that's what led us to Karkinos, which is now a fully Reliance funded company, to develop a end-to-end care solutions in the oncology field. So we have today something called as an early detection funnel, a diagnostic arm, a delivery, which is a hospital system, and discovery, which is the R&D system. Now each of these four pillars or verticals, as you might call it, have their own strengths, but they actually talk to each other. Okay, and I'll not bore you too much. Maybe in a few years I'll come back to tell you stories, but clearly you could look at public health benefits that are from an early detection point of view. Okay, you need a lab that is very high end, does molecular testing, because these are all people don't have the disease. So you have to use molecular evidence to prove that they have they're a carrier or have a mutation. Okay, that's where the diagnostics. So we have CAP and NABL accredited labs. We have 5 of them. We have 37 hospitals in which we can either we operate them or we partner with, and you can do R&D with them. So here is one slide and one data point that I leave you with. Okay, that's the map of India. Okay, those big blobs are the labs, but I'm going to really want you to focus on the fine dots on the map of India. That's 3 million people, 12 states, 85 partners, 30 months. Okay, so and all that is a molecular test done for HPV screening, because that's a molecular test, a single RT-PCR assay that will tell you does the women carry the virus or not carry the virus. If the woman does not carry the virus, you can give them a vaccine. Okay, that's a public health program that can emanate out of a genomics program. I'll stop there and acknowledge a large number of my former colleagues at CSCR IGIB, a lot of about 22 odd PhD students, 280 clinicians across the Guardian Consortium from 70 centers, of course, patients, families, and Vinod, who was a partner in crime for the last 25 odd years. I'll stop there and thank Karkinos for the opportunity to bring me here. Thank you. I'll take questions. Yes, there's a question in front. I'll take maybe one more question.
So often having a good reference genome is available, is very important for diagnostics. I'm wondering whether do we have enough normal population's reference genome in India? Because perhaps we are referring to 1000 genome sequencer or UK genome sequencing database.
So there are 2 large data sets currently available. One of which is published and publicly available. I would see the IndiGenome, which Vinod and I were sort of leading, and now it's all in public domain. You can go to the IndiGen website and still download the allele frequencies.
Mm-hmm. How many people?
1,028 people.
Okay.
Then there was this morning, so the program following that was the Genome India program, which has 10,000 genomes. A substantial portion happened in our labs. That data is already sequenced, kept, yet to be put out in the public in terms of utility. That's what Dr. Rajesh Gokhale was mentioning in the afternoon. But again, that's only 10,000. For a country like this, you need a few million. You're not there yet.
I believe so, because when we started using reference genome of 1,000 genome sequencing, 100,000 genome sequencing, that's actually a very different scale than the 10,000 versus US versus India.
So we are still where US was maybe a decade ago. Maybe,
right.
Okay, we'll require a few million to be truly representative of India, but it's a work in progress. That's it. Thank you. Thank you.